Thank you so much all for joining. We're so delighted to have Dr. Parker here for our special seminar series towards diversity, equity, and inclusion in informatics, healthcare, and society. Andrea Parker is an associate professor in the School of Interactive Computing at Georgia Tech. She's also an adjunct associate professor in the Rollins School of Public Health at Emory University and at Morehouse School of Medicine. Dr. Parker holds a PhD in human-centered computing from Georgia Tech and a BS in computer science from Northeastern University. She's the founder and director of the Wellness Technology Lab at Georgia Tech, and her interdisciplinary research spans the domains of human-computer interaction, public health, as she examines how social and interactive computing systems can be designed to address health inequities. Dr. Parker has published widely in the space of digital health equity and received several Best Paper Honorable Mention awards for her research. Her research has been funded through awards from the National Science Foundation, the NIH, the Aetna Foundation, Google, and Johnson & Johnson. Additionally, she's the recipient of the 2020 Georgia Clinical and Translational Science Alliance Team Science Award. Dr. Parker has had various leadership roles, including serving as the co-chair for the Work Group on Interactive Systems in Healthcare, WISH, and as a member of the Johnson & Johnson Morehouse School of Medicine Georgia Maternal Health Research for Action Steering Committee. We are so delighted to have you here today. Dr. Parker, I'll let you take it away.
Thank you so much, Pooja. Well, thank you all for coming, and I'm excited to be here with you today to discuss opportunities for social computing systems to address issues of health equity in communities that disproportionately experience poor health, as well as important considerations when designing such tools. So as we know, across the world, health and well-being are not equally experienced. Some groups experience higher rates of and barriers to poor health, such as racial and ethnic minority groups and low socioeconomic status households. And we refer to these unjust gaps in health outcomes as health disparities or health inequities. So let's look at some of the ways in which these health disparities are manifested. So first, we see marked differences in well-being when looking at different racial and ethnic groups. For example, let's take the topic of obesity. So obesity is, of course, a serious health condition that's associated with poorer quality of life, lower mental health, and a host of physical health issues, including diabetes, stroke, and some forms of cancer. And so here we've seen that over the years, obesity rates have risen in the US. Drilling down, however, we see that the burden of obesity is not evenly distributed. Black and Hispanic adults are much more likely to be obese than white adults. And if we look at children, we see that rates of obesity have been increasing all over the world for the past few decades. And yet again, obesity is not equally experienced across populations. For example, socioeconomic status matters for children's health. Children in low-income households are more likely to be obese than children who are in higher income families. And of course, we've seen health inequities further magnified amidst the COVID-19 pandemic, with communities of color and low-income households experiencing disproportionately high rates of COVID-19 morbidity and mortality. For example, in the US, Hispanic, Black, and Indigenous people have been much more likely than white adults to be hospitalized due to COVID. And we've also seen stark disparities in terms of COVID deaths. Black, Hispanic, and Native people in the US have been dying from COVID at much higher rates than white Americans. The fact that these significant and persistent disparities in health exist means that we as a society have failed to achieve a state of health equity, meaning a state in which everyone has a fair opportunity to achieve well-being. And reaching a state of health equity in our society will mean eliminating the kinds of gaps in health outcomes that I've shown here today. So the question that I've explored in my research is, what role might technology play in helping to achieve health equity? Well, there has been much optimism about how interactive technologies can promote well-being generally. For example, there's a large body of work in commercial innovation focused on mobile health or mHealth platforms. So mobile devices, for example, mobile phones, have several affordances that make them promising platforms for delivering health interventions and support. For example, mobile phone ownership continues to increase across populations, including lower income groups. And in fact, research has shown that populations with some of the highest rates of health challenges, such as adults with low income, are especially likely to use their mobile phones for internet access. And the mobile phones also enable the delivery of less costly health interventions than has traditionally been possible in clinical settings. And mobile platforms go with people into the settings in which they make health decisions, allowing the delivery of health interventions and support at the time and in the context in which it matters most. So much of the innovation in this space has had a laser focus on helping people engage in healthier behaviors. And this is a really important objective. Engaging in healthy behaviors, as we know, like physical activity and healthy eating, can help people prevent and manage chronic disease. And yet, behavior change is difficult, especially in the long term. So addressing this challenge, mobile health or mHealth interventions provide functionality like goal setting and self-tracking features that can help people more effectively engage in behavior change. mHealth innovations have particularly paved the way for one class of intelligent interface, just-in-time adaptive interventions. So these interventions provide support that is for the individual user and aim to not only treat disease, but also prevent it by helping people to engage in healthy behaviors. So this form of what we call precision health uses the power of AI and machine learning to create digital health interventions that are personalized to the user based on their individual characteristics, behaviors, and so on. And using sensors, data collection, and machine intelligence, we have the ability to create interventions that are not only personalized, but also dynamic, adapting over time, such that as a user progresses through their behavior change journey, they are provided with the right kind of support at the right time and at the right place to help them do things like resist the urge to smoke or engage in physical activity. And these sorts of just-in-time personalized interventions are motivated by research showing that digital health intervention personalization is important for supporting improvements in health outcomes. And so I know for this audience, this is background that you're very familiar with, I'm sure. But while research in this space has shown much potential, there are important pitfalls that should be considered. So work in this space is still nascent. More work is needed to establish a comprehensive evidence base of the efficacy of intelligent mobile health interfaces. And indeed, a recent systematic review showed mixed evidence regarding how well just-in-time adaptive interventions are actually able to impact behavior. Second, little work has been done to examine the efficacy of such intelligent mobile health interfaces within marginalized and underserved groups. And this is a major gap in the literature that needs to be overcome to understand the role that technology can play in reducing societal health inequities. And in fact, a recent systematic review found that few mHealth studies even reported important participant characteristics like race, ethnicity, and socioeconomic status. Lastly, the power of intelligent user interfaces to create personalized experiences that impact behavior change can also be a pitfall if it leads to an over-focus on shifting behaviors and less focus on the social determinants of health. So indeed, research has shown that interventions that rely mainly on individual effort are less effective at reducing health disparities than those that include a focus on social determinants of health. And so this is because health disparities are largely created by social determinants of health. Social determinants of health are the conditions in which we live and work that impact our well-being, the supports we experience from maintaining positive health, and the barriers we face. For example, our social relationships have a profound impact on our well-being. A lack of healthy, supportive relationships can make it more difficult to engage in healthy behaviors and indeed lead to the development of unhealthy behaviors such as poor eating habits and sedentary lifestyles. Research has also shown that positive social relationships are essential for psychological and emotional well-being, and that those greater positive social connections also have that those individuals who have increased social connections also have a lower likelihood of health conditions and lower mortality risk. Social relationships help support healthy behaviors through increased access to informational, emotional, and instrumental resources that can support health behavior change and maintenance. And all of these benefits are needed to help reduce disproportionate rates of chronic disease and mortality in racially minoritized, low socioeconomic status, and other populations experiencing health disparities. Also, with regard to health inequities, positive social relationships can help marginalized groups to overcome the increased barriers to well-being they face. For example, research has shown that social capital, meaning the supportive resources and benefits we can draw from strong social networks, that social capital can help buffer against the many health threats that low socioeconomic status communities face. Social capital is also essential for enabling social action that directly addresses systemic structural forces that create inequities such as racism and discrimination. And so to truly address and reduce health disparities, we need interventions that not only seek to help individuals change their behaviors, we also need interventions that seek to enhance social conditions so that they are more conducive to healthy living. So in my lab, we identified this trend of focusing on the individual in our systematic review of mHealth research focused on populations who experience the highest rates of poor health in the US. So we focused on low socioeconomic status and racially minoritized groups. And through our analysis, we found that the vast majorities of papers in our corpus reported on the design and evaluation of mHealth systems in which the target user was the individual. So stated differently, there were very few social computing systems. And this is despite, again, social contexts having powerful influences on health behaviors and attitudes. And then carrying on from this finding, we found that few interventions were designed to address the physical and/or social environments that impact health. Instead, most studies evaluated tools that provided informational support, for example, the delivery of expert knowledge, or behavioral support, such as goal-setting mechanisms. In other words, the systems were mainly designed to support individual attitude, knowledge, and behavioral change. And then finally, through our meta-analysis of the randomized controlled trials in our corpus, we concluded that overall, the interventions did not demonstrate a successful impact on health outcomes. We hypothesized that possible explanations for this may be the limited attention paid to social environments, as well as the pervasive finding across projects that interest in and use of these platforms quickly faded amongst study participants. And so our systematic review highlighted a research gap. There is a need for more work exploring how technology can not only help people develop healthy behaviors, but also help them build the social infrastructure that can help support those behaviors. And I define social infrastructure as a network of positive, beneficial relationships that can be engaged to support health, well-being, and the reduction of health inequalities. I argue that creating systems that build social infrastructure can nurture user engagement and directly address health disparities. And so today, in the remainder of my talk, I'll describe examples of projects in my lab that investigate how interactive computing systems can address health disparities by helping people to establish, enrich, and engage their social relationships. I'll describe why this is an important pursuit and provide some examples of how it can be accomplished. So I'll discuss two projects, one focused on the creation of faith-based digital health tools for historically Black church communities, and the second project examines to what extent social media helps youth develop their critical consciousness, meaning their capacity to recognize and address societal injustices that inhibit well-being. So first, my collaborators and I are investigating how mobile health platforms can address health disparities in Black communities through a faith-based approach. So as I previously discussed, Black populations experience multiple health disparities, such as increased rates of obesity, diabetes, hypertension, and maternal mortality. These disparities are created by social and structural inequities, such as racism and discrimination that create higher exposure to health threats and reduced access to health resources in Black populations. For example, predominantly Black neighborhoods are less likely than predominantly white neighborhoods to have healthy food access, and this is true across socioeconomic categories. Black populations are also more likely to report experiences of racism and discrimination in the workplace, which threatens mental health and access to social and economic resources that can come from workplace networks and that are supportive of health. Research has also found that Black populations receive lower quality health care than white populations across many quality measures. These and a myriad of other social and structural factors create health disparities in Black communities. However, Black communities are also rich in cultural assets, one of which is the Black church. The Black church is variously defined in the literature and in popular culture. Broadly, the term the Black church has referred to churches with historically or predominantly Black memberships. Drawing from the definition used by our community partner, in our work, we define the Black church as Protestant churches that serve predominantly Black and African American memberships, or those with Black pastors who are explicitly focused on engaging and building community with Black parishioners and/or communities. Churches have long been a valued cultural institution in many Black communities and have played a central role in efforts to combat societal injustices, especially those experienced by Black communities. Furthermore, these churches provide services, tangible resources, rich social networks, and informal healthcare to church members and the broader community, which are all key assets that can help combat health inequities. As such, Black church communities are important cultural entities to engage in efforts that address health inequity. Indeed, there have been many faith-based health interventions created for Black church communities. However, this work has rarely investigated the role that digital health interventions might have in supporting well-being within Black church contexts. Yet, such systems present great opportunities for overcoming challenges with existing faith-based interventions, such as the need for human and financial resources to sustain interventions and barriers to participation, such as limitations on transportation and time. As such, digital health tools offer opportunities to expand churches' ability to reach community members with their unique and rich resources. So in our work, we've tried to address this research gap and opportunity. In 2019, we started a multi-year community-engaged effort to explore how mobile health interventions could be designed with and for historically Black churches. During our first year, we conducted extensive formative work with members of our partner churches to collaboratively identify opportunities for the design of mHealth tools for their communities, and more fundamentally, if an mHealth intervention was of interest to their communities. We conducted several rounds of focus groups, interviews, and design workshops throughout the year to iteratively arrive at design implications. And through this formative work, participants characterized a set of key design guidelines for mHealth tools that were designed for their communities. For example, they expressed which health and well-being topics were of highest priority to them, such as physical activity, nutrition, and mental health. They also indicated that it was essential that the content and features of the system address their spiritual values as they relate to health and well-being. And lastly, they expressed that any system we designed needed to enable church members to provide one another with social support. With these design implications in mind, we created our resulting system using a whole person approach. And this type of approach goes beyond a focus on bodily health to also support other dimensions of well-being. So our whole person approach led us to consider a broader, more holistic view of what health can mean for church communities. And our resulting system then not only supported physical and mental health promotion, but also incorporated elements that support spiritual and social well-being as well. And so in designing and evaluating our tool, our aim was to answer the following question: How can technology be designed to support physical, social, and spiritual well-being within church communities? And in this talk, I'm going to focus primarily on the elements of the app that support social well-being. Social well-being can be thought of as the development and engagement of positive social connections that are in and of themselves health promoting, for example, because being socially integrated supports mental health and positive coping, and because social relationships create social capital that can support healthy behaviors. For example, relationships that can enable informational and emotional support that facilitates behavior change. So the app we created is called Church Connect. One central feature of Church Connect is Clara, an embodied conversational agent who we designed to function as a kind of peer health coach, and that uses conversations with the user to promote a variety of healthy behaviors, such as healthy eating and physical activity. In addition to this health coaching, Clara also shares a Bible story of the day, and we created this feature as one way of honoring a valued spiritual practice, Bible reading, within our partner communities. Finally, we also created a prayer center feature where church members can post requests for prayer. Prayer requests can be thought of as issues of concern, challenges, hardships, or other topics that a church member would like others in their community to pray for them about. When prayer requests are posted, others within the church community can see those posts and post a public reply. And church members can also save prayer requests that they view to a private prayer list. A church member's prayer list is viewable only to them. And we designed this prayer list feature to augment an existing practice that our participants shared with us. That is, they described creating paper lists of those in need of prayer in their community, along with those individuals concerned, to support them in praying for those individuals later on. So while this prayer wall feature may look similar to traditional social media posting functionality, there are some key distinctions. First, when individuals post on the prayer wall, it is a request for action, that is prayer, from a community that is driven by the value of caring for each other through exercises of faith, prayer, and social support. Second, prayer requests are not simply solicitations for help. Rather, they are a call for those within their faith community to participate in a communal spiritual discipline that is highly valued and sacred. So I'd like to share some of the findings from a 4-week field study we conducted to begin understanding church members' perspectives on and experiences with the Church Connect app, and their ideas for how future systems could effectively promote well-being within their communities. We partnered with 2 churches for this study, and we had 25 members participate. At the end of the 4-week study, 17 of these participants volunteered to participate in a semi-structured interview. Our analysis of our interview data characterized a set of community values and dynamics that Church Connect helped to reinforce, enhance, and problematically, in some cases, disrupt. We define community dynamics as underlying social processes that characterize a social group, such as church communities. These social processes establish the norms, roles, practices, and shared goals that characterize and create the identity of a particular social group. Example processes might be the ways in which social connections are built and broken within a community. We find that these community processes are essential to understand, as they can mediate the impact that a health intervention has on a community. And today I'll focus on a subset of the community dynamics that our participants discussed and the ways in which they were enacted through the prayer wall feature. So first, the dynamic of developing social intimacy. Both churches that participated in this study have long valued creating close friendships and relationships amongst church members. Our participants described how the prayer wall helped them achieve this value of social intimacy because it helped create authentic opportunities for them to communicate with one another. As this participant told us, I saw someone, on the prayer wall who I don't necessarily talk to, but I see them intermittently. But now when I see them on Zoom, because they had seen what they had posted on the prayer wall, I can be like, hey, like, how is that person that you mentioned? Or how was your trip? Imagine being able to see details on the prayer wall and begin a foundation for more. So the intimate but small windows into members' lives that were shared on the prayer wall were valued sparks for developing deeper relationships in other contexts, and a key part of what helped engage participants with the app. Additionally, some participants described how the personal life circumstances and challenges expressed through prayer requests are ways to identify church members who are experiencing the same challenges as they are. For example, church member 7 said, one of our members got COVID-19 and his wife sent us all a note. He said he felt really good by the fact that 3 or 4 of the guys who also had COVID came out on their own, basically, got on the phone and prayed with him. And they called him and he was in the hospital. So, it's having a group of people who had a similar malady praying with you. That's incredible stuff. Though this participant's anecdote describes an interaction that occurred through phone calls, he shared it with us to provide an example of interactions that he thought could be supported by the prayer wall. He helps convey the very powerful way in which collective prayer with those going through similar circumstances can have a profound impact on people. This example also helps convey how a feature like the prayer wall can help surface hidden similarities shared between church members, opening up opportunities for further and deeper connection. And indeed, the very nature of a prayer request is that people may share intimate, private details of their life experiences that they may not have shared in other contexts. And it is those intimate details and the shared prayer experience that are part of what help people build connection and deepen relationships in the church communities we studied. Another community dynamic that we identified through our analysis was that of communicating care. Providing care for the church and broader community was a central value that both of our churches held. All of our participants indicated that the prayer wall helped their communities communicate care. Participants explained how currently prayer requests were primarily shared to the broader church community when they were about extreme situations. As one of our participants explained to us, a lot of times we announce certain prayer concerns that are the worst case scenario situations. Someone is in hospice or someone is on their way out, meaning close to death. But sometimes some people are just going through mild situations. Our participants described how Church Connect helped people to share these milder health and life situations that were still significant and of concern to them. And this sharing, in turn, can enable the provision of care through prayer and other forms of social support. Now, our participants enjoyed seeing members' prayer requests and sharing their own challenges with their community. At the same time, participants worried that prayer wall posters expected to receive prompt replies to their posts. Participants' concern was that if posters did not receive an immediate response, it could make them feel isolated. One participant expressed the negative feelings that arose when he did not receive a response to his prayer request from his men's group. A men's group is a gathering of men in the church that may serve various functions, such as a Bible study group, a prayer group, or a broader support group. Participant 13 told us that it was confusing once I wrote my prayer request, and then I came back and I didn't get the level of response from certain people who I knew, like the guys from my men's group, and that felt bad. Other participants worried that if they responded to a prayer request from one person, they would be expected to respond to everyone. Of course, this kind of social pressure to respond to posts on social computing platforms is not new. However, when this phenomena occurs within the context of spiritual practices, such as prayer support, it becomes more complex. Specifically, in contrast to social support exchanges on conventional social media platforms, Smith et al. Define prayer support as a spiritual triadic experience that occurs between the person requesting prayer, the person or persons who respond to that request, and God. And thus, it is often not trivial when someone does not respond to a request for prayer. Instead, it can negatively disrupt a sacred spiritual practice. The last community dynamic that I'll mention is building intercommunity relationships. In the current iteration of Church Connect, users can only interact with members of their own church. And yet, participants were aware that other church communities were engaged with our project. Our participants discussed wanting to interact with those other church communities through the app. They described how such interactions could increase their access to beneficial institutional resources across church communities, and that it could also help expand and diversify their social networks. Both of these outcomes would then help them to access increased health-enhancing resources, such as the health promotion events and services offered by different church communities, and peer support from distributed church members that were also pursuing behavior change. In addition to being of practical value, participants describe a desire to connect with other churches because, as one participant told us, it can help them feel like they are a part of something bigger than themselves or bigger than even their own church community. This participant highlights how connecting with a larger community of people of faith can be not only practically useful, but also empowering and spiritually fulfilling. So, in summary, our qualitative study helps characterize how participants' perspectives on an mHealth tool we designed for and with Black church communities. They characterize our participants' perspectives on how these kinds of tools can be designed and the value that they can bring. Our findings demonstrate that there is great potential for faith-based digital health tools to support well-being in a population that disproportionately experiences poor health and barriers to well-being. In addition to supporting physical well-being, Church Connect aims to support social connection and spiritual practices. And our findings highlight several community dynamics that Church Connect helped to support, ways in which it disrupted those dynamics, and opportunities for the design of future faith-based health interventions. And more broadly, our findings highlight 3 ways in which digital health interventions anchored within Black church communities can help build social infrastructure that addresses health disparities. So first, our findings show the value of tools that help people to establish relationships, not only within, but also across faith communities. This finding speaks to a larger opportunity for future systems to connect people across community-based organizations, such as community groups and schools. Doing so may develop networks that can be drawn upon to derive social capital, again, meaning material and social resources that can facilitate well-being and enable marginalized groups to overcome disproportionate threats to well-being. Future work may consider exploring how systems can ease creation of these connections, for example, through intelligent relationship brokering that uses AI and machine learning to connect people to others with similar experiences or who can provide needed supports for well-being. Additionally, our findings showed how participants valued the social intimacy afforded through the Prayer Center and Church Connect. Enriching relationships is a key step towards building bonding social capital, meaning strong social connections that can be relied upon for emotional support. Bonding social capital is essential for reducing health inequities, for example, because it creates access to emotional support that can buffer the negative health impacts that arise from experiences of racism and discrimination. Our evaluation of Church Connect demonstrates how, when designing for hybrid communities that bridge the physical and virtual worlds, there is an opportunity to create sparks in the virtual world that lead to deepened interactions in the real world. In our work, these sparks came through prayer requests posted in the prayer wall. But future work should further investigate what those technology-mediated sparks could be that open doors to deeper intimacy and connection in the real world. Additionally, our findings highlight the potential value of tools that help people engage relationships with their other church members to receive and provide care. Our work highlights the value of systems that provide new ways for people to signal a need for care and for those interested in providing care to learn about those opportunities. Technology provides a lightweight way for individuals to do this signaling. At the same time, we also found that there were important community expectations to navigate, for example, around prayer request response timeliness. Future work should continue exploring how to deftly navigate such concerns, particularly in the especially sensitive context of church communities. Lastly, overall, our work speaks to the importance of intentionally examining a group's community dynamics as a key design step for understanding how, why, and if a local collective, such as a faith community, would like to engage with a digital health tool. There are many other community-based organizations that warrant exploration in terms of how digital tools anchored within these organizations can help people build social infrastructure that reduces health inequities. And so now for my last case study, I'd like to turn our attention to how technology might help young people engage their social networks for another purpose, to develop their capacity to engage in social action that counters health inequities. So our work has focused specifically on youth and exploring how social computing can help develop youth's ability to address societal injustices. And there are several reasons why this area of work is incredibly fertile ground and worthy of study. So first, we know that youth are using social media for socio-political purposes. For example, to advocate for causes and engage in collective action. Indeed, they are actually more likely than adults to use social media to advocate for social change. And second, youth are more likely than adults to use social media as a news source, suggesting that they are learning about societal issues in large part on social media. And so much work has investigated the relationship between social media use and offline political and civic engagement broadly. However, to our knowledge, prior work has not investigated whether youth's use of social media for socio-political purposes supports their critical consciousness. So what is critical consciousness? Well, Paulo Freire refers to critical consciousness as an individual's capacity to analyze and act against systems of oppression that perpetuate inequalities, including health inequalities. In our work, we view this capacity as an essential construct to study within a digital health equity agenda. Building up this capacity is key to growing a society that recognizes and acts against oppressive systems that create marginalization and health inequity. Now, given the affordances of social media for supporting socio-political engagement amongst youth, a pressing open question then is, are these platforms helping youth become more critically conscious? Notably, critical consciousness is not only about being civically engaged or politically active. It also speaks to one's capacity to analyze systems of oppression and a motivation to enact social change that directly addresses marginalization. So specifically, critical consciousness has three components. First, critical reflection refers to a person's awareness of oppressive systems that create and perpetuate social inequalities. Second, critical motivation describes a person's motivation or impulse to take action against systems of oppression. And third, critical action refers to civic and socio-political action taken to combat oppressive systems. As people increase in critical reflection, motivation, and action, they increase in critical consciousness. With this in mind, we conducted a study to investigate the research question, to what extent is youth's frequency of socio-political engagement on social media associated with their critical reflection, critical motivation, and critical action? And this work builds upon our several years of prior work characterizing how youth activists use social media for community organizing. So now in our current work, we are moving beyond a focus on formally trained and supported youth activists to understand the more general youth population, and specifically the role of social media in supporting or hindering their critical consciousness development. So we conducted an online survey to explore our research question. This survey was disseminated from March through July in 2022. Our respondents were high school aged youth, and through our analysis of 339 respondents' data, we tested our hypothesis that youth's frequency of socio-political engagement on social media would be positively associated with their critical consciousness, specifically their levels of critical reflection, motivation, and action. We measured socio-political engagement by asking respondents to report their frequency of engaging in socio-political activities on social media platforms, such as how often they learn about or post on social media regarding political, social, or local issues. We assessed level of socio-political engagement across 6 platforms: Facebook, Twitter, Snapchat, Instagram, TikTok, and YouTube. And we measured critical consciousness using the short critical consciousness scale, which allowed us to measure critical reflection, motivation, and action distinctly. For context, and as one of our covariates, we also measured civic program participation, meaning how frequently respondents engaged with civic-minded organizations in the past year. And we conducted a multiple linear regression analysis to explain the degree to which the frequency of socio-political engagement on each of the platforms we studied is significantly associated with these 3 components of critical consciousness. We also included 2 open response questions to collect qualitative data that could help us triangulate our quantitative findings. And these questions asked respondents to describe how they feel social media has helped them learn about and become motivated to address and take action to address political, social, or local issues in society or in their community. And we also asked how they felt social media had hindered this learning, motivation, and action. So our findings showed that when it comes to the question of whether social media supports critical consciousness development, well, it's complicated. So with respect to critical reflection, we found that increased sociopolitical engagement on TikTok is associated with greater critical reflection. However, increased sociopolitical engagement on YouTube is associated with lower critical reflection. For sociopolitical engagement on Facebook, Twitter, Snapchat, and Instagram, we saw no associations with critical reflection. Now, with respect to critical motivation, we found that increased sociopolitical engagement on YouTube is associated with greater critical motivation. However, increased sociopolitical engagement on Snapchat is associated with lower critical motivation. And then for the remaining platforms, we saw no associations. With respect to critical action, we found that increased sociopolitical engagement on Instagram is associated with greater critical action. And then for sociopolitical engagements on the remaining platforms, we saw no associations with critical action. So what are the takeaways from this set of findings? Well, we found that sociopolitical engagement on some specific social media platforms has positive associations with critical reflection, motivation, and action. However, there was no one platform that was positively associated with all 3 components of critical consciousness. Furthermore, engagement on some platforms actually had a negative association with critical consciousness components. And then there were two platforms that had no positive associations with any component of critical consciousness, Facebook and Twitter. So why do we see some positive and negative associations between critical consciousness and sociopolitical engagement on social media? Well, our qualitative data provides some initial insights. So first, let's look at why we might see positive associations between several critical consciousness components and sociopolitical engagement on social media. So our participants described the facets of social media that they felt helped build their critical consciousness. So first, they discussed how social media helps them to hear the personal stories of those experiencing oppression and how these narratives help them to learn about social issues and motivate them to take action to address them. So as we see here, this participant says that social media helps me learn and hear about many personal stories where people have had to deal with racist, homophobic, or sexist things in my community and the United States in general. It helps me stay informed and more motivated to take action. And so that her quote speaks to both, critical reflection as well as critical motivation and action. Participants also reflect that social media exposes them to topics that are not covered by traditional news media, such as television and newspapers. Through content posted by those in their social networks, they are exposed to new ideas, concepts, and perspectives. For example, one participant said, social media helps me see the underdogs or smaller people's point of view instead of the big people in the mass media. Another participant mentioned that social media has provided me with information on so many issues and given me resources to further research these issues. For example, a TikTok explaining the concept of white feminism has taught me a bit about the concept, but I want to learn more through a book that the creator recommended. So in summary, social media may be supporting critical consciousness through compelling personal narratives and coverage of justice-related topics that are less covered in traditional media. Alternatively, already critically conscious youth may be seeking out these social media platforms because of these affordances. And participants also described factors that inhibit their critical consciousness. For example, several participants described how online discourse about socio-political issues is often judgmental and antagonistic, and that this makes them fear speaking up and taking action. For example, P116 said, sometimes the content is attacking those with opposing beliefs, which is very hurtful to me because I don't think people should be disliked because of their beliefs. So sometimes this makes me not want to address issues in my community. P17 was also scared to speak up, noting, it does stop me sometimes because it can be scary to speak my opinion on a highly controversial topic. Once I state my opinion, people are open to thinking or saying whatever about me. And then P178 provides an additional perspective, noting that while they always want to learn, which is an example of critical reflection, they are inhibited from speaking out due to concerns over cyberbullying and doxing. Additionally, participants described what they view as extremely distressing and overly pessimistic content on social media. Prior work has shown that when people are exposed to distressing content online, it can demoralize them and inhibit their participation in collective action. So we found that this phenomena was present in our data set as well. So for example, P145 describes how there are times when the information I see on social media is more triggering and angering than helpful to my knowledge. And at those times, I would rather do anything to avoid it than to address or educate myself on it. P167 also describes how social media content is off-putting by saying, there's just too much information. There's always something going wrong, and there's nothing I can do to change it. I don't like to consume as much of that content as a result. It's pointlessly depressing. So these quotes provide examples of how antagonism and distressing content on social media can inhibit critical consciousness, and may be one reason why on several platforms we see no association or a negative association between socio-political engagement and critical reflection, motivation, and action. So in summary, our work suggests that social media can help youth engage their social networks in a way that supports critical consciousness development, and or that social media is a place where youth who are already critically conscious go to engage their networks for socio-political purposes. This kind of socio-political activity and critical consciousness development is essential for building engaged citizens who are aware of and motivated to take action that counters societal inequities. Our work further shows how these associations between critical consciousness and social media use vary by platform. So more work is needed to investigate the specific affordances of different social media platforms for supporting and inhibiting critical consciousness. And there is opportunity to explore socio-technical design opportunities for social computing tools that more effectively support critical consciousness by helping to counter antagonism experienced online and youth's overexposure to demotivating content. So to conclude, there is a need for continued research focused on how digital health systems can address the persistent health disparities that exist in our world. The projects I've described today have highlighted several ways in which technology can help to build social infrastructure. These examples help to characterize how interactive computing systems can move beyond a primary focus on shifting individual health behaviors to more fundamentally impacting the social context that help to support healthy behaviors, well-being, and health equity more generally. So first, the work I've described shows how when we design tools that help people establish community relationships, this can help support the building of health-promoting social connections. Our work and prior work has shown that positive social connections can enable access to health-promoting resources, facilitate subjective well-being, and a sense of community. Second, I've demonstrated how when we create tools that help people to enrich their community relationships, it helps build bonding social capital that can then be drawn upon for social support. And lastly, I've provided examples of how technology can help people engage their social networks to care for one another in a community setting, and also to build up their critical consciousness. Each of these benefits drawn from social relationships can help combat health inequities by helping people to overcome, cope with, and directly confront disproportionate barriers to well-being experienced in marginalized groups. And I encourage future work to further examine design opportunities for digital platforms that help build social infrastructure. So I'll conclude by thanking my students, collaborators, community partners, and funders that have made this work possible. And thank you so much for listening.
Thank you so much. Lots of virtual applause. If folks have questions, could you just raise your hand and I'm happy to call, or Dr. Parker, if you want to call. I see we have a question from Tara.
Yes, hi. Thank you so much for your talk. I really appreciated it. Especially the first part you shared about working with the Black church, and the work that you, like the way that you approach that problem there. I also want to share, I'm a Baha'i, and the Baha'i faith is one that really values community building efforts and supporting and engaging with community organizations and engaging with them to lift members up. So I really appreciate the perspective and approach of your work to leverage these existing community networks and effort, and also the humility that it all takes to recognize and learn what's valued in the community and honor what's important to them and making the tool actually really useful to them. My question is about kind of the extension of this work to health applications, and if you have ideas about how these efforts can kind of be scaled beyond mobile health, and thinking about how hospitals can also better partner with groups and organizations like the Black church, as you talked about in your work, to address disparities in health and other contexts.
Yeah, that's a good question. Okay, so how can we move beyond, these kind of faith-based health interventions solely being grounded in like a church context to also connecting with healthcare systems? Is that your question? Okay. Yeah, so I mean, one, I think great opportunity is, so many of the churches that we work with have existing health ministries within them, where members of the church are in the healthcare profession, and they help to facilitate those ministries. So they're nurses, they're doctors, they're therapists, et cetera. And so they provide a really natural bridge from like a just sort of a community engagement context from the community to the more formal healthcare institution. And so I feel like I would want to start with them and sort of understanding how they see the linkages between these two institutions. But I do think that there's like a really great opportunity there. I mentioned that, in racially minoritized communities, we see lower healthcare quality, there's lower trust as a result of that of the healthcare establishment. And so faith-based institutions might be really interesting opportunity for healing some of those fractured relationships and that lack of distrust and sort of fueling efforts to try to improve healthcare quality. So I would say that would be one opportunity. I think there's also, an extension to the work that I talked about today. We're building upon that app that I mentioned to support COVID vaccine promotion. And as part of our team, we have, various health providers and individuals who are also members of churches, but also healthcare providers. And that has been like, a very direct, we've had to, of course, very directly tie our work to formal healthcare to be constantly understanding, okay, what are recommendations around COVID vaccines and making sure that the information is accurate and aligning with what providers are communicating to their patients. And so I think there's a natural way to connect there too, to make sure that, information that is being disseminated within a healthcare context is in line with what is being, supported and shared in a digital health context it's grounded in church communities, especially because, as we've seen with COVID, when we have sort of differing messages about what's going on and what one should do, that just leads to further breakdowns and trust. So those are some ideas.
Great, thank you.
Mm-hmm.
Amanda and then Adrian.
Thanks so much for your talk. And I come from a public health background, which has found that church and faith are an important bridge for interventions and their uptake. So like you had mentioned, like trust is a huge issue. So I'm really grateful for your work. And I love the fact that there's existing efforts in digital health to consider faith and design, and also contextualizing social media in a way that resonates with faith-based communities. My question is in reference to the second study. Did the participants engage in other forms of social media? And if so, how did their usage compare with the resource that your research group had developed? And also, did you get any feedback on any of the potential deleterious effects regarding like social pressure to respond?
So let me make sure you're talking about the our youth and critical consciousness study.
The second study.
That was the second study, or are you talking about?
Oh, is it? It's the first.
Oh,
the
sorry.
first
I guess
study.
depending on how you define. Yeah. Okay. The church's study then. Okay. Okay. Then I'm sorry. Can you? Because I was thinking about your question in context of the social action. Can you restate?
I apologize. It's on the church's study.
Okay.
Whether the platform that they use, if they use that differently than other social media platforms, and when it came to sort of like social pressure to respond for prayers and not receiving the feedback that they had hoped for. Did you capture any data on that?
Got it. Okay, thank you. Did they use it differently than other platforms? I know that they definitely discussed using other platforms. So like Facebook, for example, and the churches varied in their use of technology before we came in to communicate with one another. One of our churches very tech savvy, another not so much. And so, they did discuss things like, okay, Facebook is a tool that we use to communicate with one another sometimes, but it's not this sort of like special purpose platform. And so a feeling that there's sort of like all sorts of things happening on Facebook, but this is a dedicated platform that has spiritual practices baked into every component of it, and so that it being valued because of that. And then the social pressure to respond. So it was a short-term study, right? So this was a 4-week study, but we definitely, as I described, there was a concern, and as that one participant's quote highlights, that it didn't feel good. And it had a negative impact when they would post and they wouldn't get much response, especially when they had in mind, particular people that they feel like should be responding based on their offline connections. And so I think that, over time, if that persisted, I could definitely see it leading to drop off in engagement with the system. And so we talked about different ways to establish community norms. This work, we've been sort of deeply engaged consistently with our communities over time. And so there's been a lot of iterative back and forth and even just like informal conversations about how these tools should be developed. And so, I think that we would work together, like sort of the vision. We started this work before COVID. And the vision for this tool was that it would be not something that we would just sort of drop into the churches and then leave and see how they use it, but also try to work with them to think about how they could really integrate it and use of it within their existing rhythms within the church. And so one of the things we've really wanted to do, and hopefully we'll do more so coming up, is to have them think through things like, okay, let's develop our own community guidelines and expectations and make that really clear and make that explicit. So I think something like that could help. We certainly could build in affordances into the system. We've thought about things like, okay, do you remind people that there's a post that they haven't responded to? But it's a lot of nuance to navigate, but I think super important to make sure that not only do we not, lead to drop off in system use, but then more importantly, sort of, fracture relationships that are really important and meaningful.
Thank you, Dr. Parker.
I want to be mindful of time, so I know we're right at 3, but Dr. Parker, if you could stick around for a few more minutes for this last question, that would be awesome.
Sure.
Thank you so much, Dr. Parker. I really appreciate your talk, and just want to echo what the previous commenters have said about especially the framing of this research and the purpose of technology and how important that is for us as a DVMI community to really engage with and think about. My question is more from an HCI perspective and about personalization. And you've talked about this in a couple of the answers that you've just given about how even though this technology is really being designed for a specific population of, Black faith-based organizations and communities, the Black church is not a monolith. And so there's still a lot of difference among each individual. And when we think about different ages or different, people whose parents came from different countries, or whether they were from like the Black Baptist South,
Right.
They might respond differently and engage differently, maybe even use different language. Like I saw prayer warriors, I think is something that some people are probably very much used to using, and other people might not really like that type of terminology. So even from like a small personalization to like a big scale personalization, how can you think about like approaching that aspect? Absolutely.
Basically everything you said, yes. Yeah. So, I mean, we saw huge amounts of variation in what participants, how they envisioned this app, how they use it. The age was a big factor. Just even, just sort of, we had like much older adults, participating in our study, and then super tech savvy young people, and even like our partners talked with us about that being something that they contend with within their church communities. Like, how do they even as a church support like this super diverse set of individuals? And then even, we've we wrote one paper about this because we spent a lot of time, like, how do we even, what terminology do we even use? What do we even mean when we say the Black church? What is that? And so trying to understand how they define it themselves, and trying to have that guide us. But even realizing that is varied, especially as these churches become more multicultural, intentionally wanting to become more multicultural. And so, yeah, there's a lot happening there. And personalization, one of the things that we have started exploring is even personalization. So I didn't talk much about it, but Clara, this embodied conversational agent, that's a big part of the app, and there's a lot of health coaching, and so there's a lot of dialogue there. And so our team creating that dialogue and thinking about how, what level of religiosity should she speak to? Should she be constantly integrating Bible verses? Should she, like you said, like terminology? And so part of what we're experimenting with now in our trial is like tailoring based on users religiosity level. But even that is like crude, right? It's super nuanced. It's like you can complete a survey, but that's not going to necessarily map onto specific clear specific directions for what how the agent should communicate with you. So I don't have a good answer, except that, yeah, it's super complicated. I feel like, it's just like that consistent question we have with this kind of community-based work. How can we balance, like you said, recognizing that none of these communities are monoliths and wanting to personalize and sort of doing that in a tractable way. Yeah, let's keep.
I look forward to reading your papers about it in the future. We'll keep you posted in that way.
Perfect.
Thank you so much.
Thank you.
Thank you so much again for this wonderful talk and sticking around to answer these questions. So appreciated and so excited for the next steps of this.
Thank you so much. Thanks for having me. Thanks for these great questions. I'd love to connect with you all at some later point, but yeah, thanks for having me.
Absolutely. Thank you. Have a good one, everybody.
Thanks. Bye.